Over the last 12 years, the Department of Radiology at the University of Florida College of Medicine has conducted a simulation-based evaluation of radiology, resident competence, in critical care imaging. 325 residents interpreted this case of pedicle metastatic disease as one of 65 cases during an 8-hour simulated on-call shift, with a median score of 2 out of 10 and an overall average score of 2.58 out of 10. Overall, the average number of points lost out of 10 to observational discipline was 7.41. At the same time, 0.02 points were lost due to interpretive errors on the part of the residents. We define an effective report to be one which achieves scores between 7 and 10. In terms of letter grades, this would be an A or a B. In this most missed case, 7% of residents produced effective reports. We define a report having a critical error to be one with scores between 0 and 2. In terms of letter grades, this would be an F or a D. In this most missed case, 68% of residents produced reports with critical errors.
So, just for added emphasis that I've been emphasizing all through a number of the cases I'm responsible for providing this feedback resource for you, I'm going to re-emphasize that you must have a system for looking at every study that you look at. Whatever your routine is, stick to it. It needs to be methodical, it needs to be complete, and it needs to be done on every study. And this is another example of that discipline. I will also make you aware that this is the type of approach we take in our Woody Learn resource, Wisdom and Diagnostic Imaging, as our online learning resource at the University of Florida. It's open to people who want to explore our curriculum and learn how to practice the kind of discipline I'm talking about in both advanced imaging techniques and plain films. So this is an example of how to stay out of trouble in lumbar plain films, which still we see plenty of. This is a patient who is a 65-year-old male with back pain. Many people get plain films of lumbar spine for back pain without red flags. You know, some neurologic deficit, history of cancer, that kind of stuff. So you see these all the time. And as I've said before, we're going to have a routine looking at that. My routine, first of all, is to look for anatomic variants. I establish how many non-rib-bearing vertebrae they are, just so I'm labeling these right. So, because labeling spinal levels wrong can lead to some significant downstream problems if there's ever going to be a surgical procedure. So you want to be sure to establish how many non-rib-bearing vertebrae and how you're going to refer to each motion segment. That's what I do first, even before the soft tissues. And if you've listened to 3 or 4 of the other cases in this neuroradiology set, I've emphasized that principle in those other cases as well. In this situation, I look at the soft tissues first, as I do in all of this. Now in lumbar spine, the soft tissues are not so revealing most of the time. In this case, they may not produce some clues. There's been a nephrectomy on the left side. That's a pretty good clue that the patient had something wrong with that kidney. It might be cancer. You might not know. We weren't given that history, but the kidney's missing. So the soft tissues might give you some clue. They might give you, in an acute setting, they might give you a localized ileus. The psoas may be absent. Those sort of old radiographic things on radiographs of the abdomen. Soft tissues in the lumbar region, I think they're more useful in the pelvis with the pelvic sidewalls and all, but I still look at them, and a bowel gas pattern, and whether there's gallstones, and whether there's kidney stones, and the psoas lines and all that, right? Then starting on the bones, you must be meticulous. You must look at every pedicle, every spinous process, and every end plate. Much like looking at the fourth ventricle on every brain CT you see. If in fact, for some reason, that doesn't happen on every study you read, you will regret that on behalf of some patient someday, because you will miss something, like vertebral osteomyelitis, like early detection of a metastasis. I like to look at the pedicles first, and that's the point of this case. Pedicle, 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 no pedicle. We all know that the pathophysiology of metastases, the most vascularized part of the lumbar spine is that area at the junction of vertebral body and pedicle. That's where Mets go preferentially. They can go vertebral body too, of course. Missing pedicle, met until proven otherwise. You might even wonder about the cortical margin of the vertebral body down here. Okay, so that's the point of the case. If you got the missing pedicle, you got the case. If you said it was cancer, you got it. You got a 10 out of 10. I think that's the way the grading goes. But let's go back to the discipline, which is more important than the case, right? So spinous process. That's very useful in trauma for alignment. It's a rotational abnormality, or is only rarely a missing spinous process. Then end plate. Check every end plate. Now, the ability to recognize the end plate varies a little bit because this centering of the beam makes a difference. So whether you're going to see it as a fine white line, whether you see it on both sides. So, not seeing an end plate here and here very well makes me want to see it on another view. It doesn't make me want to necessarily call it abnormal. And of course, all of this gets tougher in the patients a little older and have a little less bone density. So that's the lesson of the case. The sagittal view, it's the same discipline, right? Now, the view of the pedicles and the remainder of the posterior elements, there's a lot of overlap. The findings can be really pretty subtle, especially if you don't have oblique views to get that look at the posterior elements. You can see that 5, 4, 3. I'm not sure I would pick that. I'd probably call it overlying bowel gas, on the lateral view. But what you see on the lateral view is, remember, I told you about the beam angling and the end plates not being seen very well on the APs because of that. Well, here you come to the lateral, and then you do end plate, end plate, end plate, end plate, that kind of stuff. So the point of this case, what is it? It's to emphasize what we do in our Witty Learn modules, on our radiograph modules. We have one on the lumbar spine, cervical spine. We have abdominal plain films, AP, chest, 2-view chests, and extremities, I think. That's sort of a whole plain film, except for mastoids and sinuses, I think. But I invite those of you who have not had sufficient exposure to the discipline of reading plain radiographs to visit the site and practice. We have practice cases for all of these things, and teach you observational discipline. And we have practice cases available to see if you've actually acquired these skills. In this case, with regard to acuity, of course, this requires the discovery of a new aspect of a cancer in this patient. His kidney was taken out many years earlier. Whether it's metastasis from that kidney cancer or lung cancer, who knows? But of course, this is a new discovery of a malignant problem. And of course, you have to call somebody and document that in your report. Although the acuity isn't high, the need for non-routine communication and documentation exists.